Okay, so the time is now, and let's start today's meeting. Welcome everyone. My name is Peng Cheng Sun from Postmedical. So firstly, we are very glad to have all the people together to join today's webinar. Today's meeting name is AI Empowered Comprehensive Coronary Circulation Assessment, more than what we have seen. And also today we are very glad to have two speakers from China and Chinese Hong Kong to share two very interesting topics. And first, let's welcome to invite Professor Tu from Shanghai Jiao Tong University. And Professor Tu, he's the distinguished professor of biomedical engineering school in Shanghai Jiao Tong University, and also he's the guest professor at Erasmus medical centers in Netherlands. And also, Professor Tu invite a lot of different patents, including the method of computational physiology and plaque vulnerability from different image modality, including angio, CT, OCT, and IVUS. And also, today we are very glad to have a Professor Tu to give the first lecture, AI enhanced comprehensive evaluation of coronary artery disease for the decision making and the PCI optimization. Professor Tu, please.
Thank you, Peng Chen, for the introduction. Good evening, everyone. Thanks for your interesting to take this evening time to join the webinar. So let me share my screen. Can you see my screen?
Yes.
Okay. Okay, I will start. So today I would like to take time opportunity to introduce the AI enhanced comprehensive evaluation of coronary artery disease for decision making and for PCI optimization. So this is the disclosure. So where we took this research project at this moment, as we know that in several patients you have multi-imaging modality like CT, angio, and intracoronary imaging, and these are all more or less separate, and the interpretation depending on the user self. So it's less reproducible, and the different imaging modality it's less intuitive to combine them. So over the last few years, we have been trying to develop a solution to optimize the workflow and to extract the quantitative information from each imaging modality. So now we have the co-registration between CT and angio, and also co-registration between angio and intracoronary imaging. And for each imaging modality, we calculate the physiology, meaning CD mu-FR or angio mu-FR or the IVUS OCT mu-FR, sometimes we call it OFR, UFR. And from CT, we also have plaque characterization. And for lesion vulnerability analysis from angio, we call radial wall strength. And we have CFR and angiographic microcirculation resistance. And for intracoronary imaging, we have the lipid to cap ratio and stent analysis. So over the next 20 or 25 minutes, I'm going to go through this solution. So first for CT, we now have the solution to do an on-site automatic analysis of coronary plaque composition and the CT mu-FR within 2 minutes. So using AI, we do the centerline extraction, lumen and vessel border detection automatically using artificial intelligence. And then we have this adaptive Hans unit-based plaque characterization. You can characterize the plaque composition like lipid green is the fibro and the white is the calcium, and sodium in 3D. At the same time, you will get the CT mu-FR at every location, and also the recent version include the sustained myocardial mass. So you can try to get a quantification of the sustained myocardial mass at every location or for every side branch. So you can understand whether, assess whether the side branch is worth to save or not. And we also try to bring the CT with angio in the cath lab. So this is the very latest development that was shown in the EuroPCR in the first live case by Javier Scanes. As you can see that the CT information can be superimposed on the angiogram. You can see that the black characterization is overlay on top of the angiogram. So you can easily see here you have a calcium, and this will help you to determine the landing zone easily. And for patients with CTO, you can also show the distal segment, which is not visible in the angio. So this would be helpful to also understand how to advance the guide well, and also you can try to analysis cross-sectional level here to see the position at the entrance of the CTO, whether how the plaque characterization, how the plaque distribution. This could be useful in the in some of the complex case, and at the same time in CT you get the optimal viewing, which can help you to get the optimal view for angio. So we believe that Blink CT in the cath lab would help for PCI planning and optimization. So this is very latest development, and it's integrating the CTA Plus software by Postmedical. It's also CE mark. So for the CT, we did a couple of validation. This is the first. So we have a few retrospective analysis that are published before, and this is the study is the first prospective study. It's called CAREER study. So the CAREER study is really to evaluate the CT-MIRFA analysis on site and using the core lab advanced reference standard. The study was published in Euro Intervention. As you can see, using the core lab physiology standard, the CT-MIRFA has a diagnostic accuracy of about 89%. As you can see, it's better than the derived diameter diagnosis. How about the plaque characterization? So in order to do the validation, we use this correlation. So for CT, we correlate with angio. The solution had been shown before. And for angio, we correlate with OCT, and then we can use the angio as a link to correlate the CT with the intercon imaging. So have them match cross-sectional level. As you can see on the right side here, the sideburns from OCT, sideburns from CT, as you can see also from here. So it's a good matching. And then we can compare the plaque characterization between CT and angio, CT with OCT. So here you have OCT plaque characterization. This you have the CT plaque characterization. So before I present the validation result, I'd like to introduce a bit about the OCT plaque characterization that we already published in 2021 and integrate into the OCT Plus software by Postmedical, so it can automatically calculate the plaque composition in the entire pullback and show them in 3D. So we develop a new index called lipid to cap ratio. We believe that this is a better vulnerability index. It's a little bit different from the TAPFA. So for TAPFA, the definition is a binary variable. So it defines as a cap thickness less than 65 and the lipstick arc more than 180. In some papers, it's N19. So it's either TAPFA or non-TAPFA. For example, plaque A is a TAPFA, but according to this definition, plaque B is not. But however, we believe that this larger lipid burden will have more consequence in the clinical result. So we have this lipid to cap ratio is defined by the lipid burden divided by the cap thickness. As a continuous variable, the higher lipid to cap ratio, the higher risk. So according to our definition, and B has a higher LCR than A. So plaque B has a higher risk than A. But according to TACFA definition, plaque A has a higher definition. So these two sometimes can be different. Just explain the difference. So in order to compare them, we perform a study in 915 vessel, non-covered vessel. We perform OCT and have a 2 years clinical outcome as a follow-up as endpoint. As you can see, the LCR has a stronger predictive value compared to TACFA. This was attractive. So using this LCR as a reference standard. So because in the study we identified that the lipid to cap ratio higher than 0.33 is a good threshold to define the risk, and then a risky plaque. So then in this validation study compared with CT, we're using lipid to cap ratio as the reference standard to identify the risky plaque or the vulnerable plaque from OCT. And then we analyze the CT parameter, as you can see from the middle here, the plaque volume and the lipid volume, and also maximum plaque burden, and also when the high risk plaque feature from CT. So we have 4 traditional CT high risk plaque feature. One is the sporty calcium and the post remodeling and low attenuation and napkin ring. So if you have more than 2 features, it also predict the lipid to cap ratio vulnerable plaque. And the right side showing the TACFA has a similar trend, as you can see. So in this study, we found that the AI-based CT analysis, this plaque burden is still a good predictor, and also the lipid volume as well. So with this technology, we perform the validation or perform the analysis for the using the Korea study, and this is the main result that was published or presented EuroPCR this year. So we identified actually if you have a CT-MUFA higher than 0.80 and also 3-vessel CT-MUFA, if you add them together, if 3-vessel CT-MUFA higher than 2.65, so if you have both, then the clinical result is quite good. But if you can use these two, you will reduce 40% of the unnecessary invasive coronary angiography. So if you have these two, 40% of the patient you don't need to send to the cath lab. And then the follow-up, so for up to 4 years, if you count that for those patients sent to for these 40 patients, if you count them if you do the invasive coronary angiography or PCI as event and also the other event together, you see the event rate after 4 years is 13.8. This is more or less comparable to if you're sending all these patients to the invasive cath lab and using physiological guide PCI and don't count PCI as event, only count the future event, future event, but don't count the index PCI as the event. So I can see that these are more or less the same. It's not statistically significant. So using this tool, you can reduce some unnecessary revascularization and save some result. And if you follow up this different vessel up to 4 years, as you can see, CT-MUFA and delta CT-MUFA also predict 4 years adverse event, and also the plaque burden as well is a strong predictor as well, as we saw in the previous validation study. The plaque burden, volume of plaque burden, is also a good predictor for OCT that will have a vulnerable feature. So this would predict a future event. Another study that was published in radiology that in collaboration with Johns Hopkins University Hospital, we're using the Core 320 study dataset to do the analysis against the CT-MUFA, at the moment still called CT-QFA, has comparable, let's say, comparable predict capability to predict future event compared to the other group, which is SPEC together with invasive coronary angiography. So I'm going to the next to the angio. So the angio, we proposed like a more comprehensive analysis from a single angiographic run. We can derive the physiology, the latest version called MUFA, and then we can also calculate angiographic microcirculation resistance. And recently, we extend to volumetric analysis instead of single vessel analysis. I will come to that later. And using both resting and hyperdynamic projection, we can calculate CFR. And also we have this radial wall strength to calculate plaque vulnerability from the angiogram. And this can be analysis very soon, very fast from a single angiotic run. So this was the best innovation in 2022 during the EuroPCR. So the angio work start from the QFR. So at the beginning, we proposed the first generation QFR, and the phase 3 China clearly demonstrated the QFR as better than angiogram, as a better clinical outcome when guiding the PCI. So it reduced about 35% of the adverse event in 1 year. And but at the same time, we recognize that the first generation is less automatic, and also another limitation is that it's a single vessel analysis. So in a single vessel analysis, I can see from the figure here, in the QFR computation, you need to reconstruct the healthy lumen, which is good. So if you don't add the side branch, so you can only, or you can do the best is to do a linear tapering reference lumen. And this will be less accurate for bifurcation reasons. So you will have a overestimation distal to the bifurcation and underestimation proximal to the bifurcation. So this is similar like QCA. If you do a single vessel analysis, you will have a less accurate result. So in the second generation, we propose the mu-FR. The mu stands for mu-Loi. It's a bifurcation fractal law. So the mu-FR actually is taking the side branch into consideration. As you can see from the left here, all the side branches were detected, and the size of the side branch is trying to give you a better estimation of the healthy lumen close to bifurcation. So we have this step-down reference diameter, which is more or less the true anatomy before you have stenosis. And the third improvement is in the using the artificial intelligence, you can automatically frame counting as well as long lumen contouring. So this would be more reproducible and faster. So now using the single view MUFR, the analysis can be performed within 1 minute. And if you follow a good angiopic run, maybe 10 seconds enough. So it's much faster compared to the previous one. And single view will be easily to perform in practice, because two views, sometimes you have overlap in second view, it's difficult. So we want to see whether the single view is accurate enough. So we perform a validation study, compare the single view versus two view. And to our surprise, in our study, we found out that the single view is as accurate as the two view 3D MUFR. And the reason I think can be explained that in theory, two view would be add more information. However, in practice, the second view is less optimal as the first view. So sometimes it compromises the result because I have more overlap, more for certainty. And in addition, there's another technical issue here. So many of the lesions, you have a eccentric lesion, but the lumen can be symmetric. For example, in this case, you see the lesion is grow at one side, but the lumen is asymmetric. So eccentric lesion does not mean the lumen is asymmetric. So in this case, you see that if you have taken this projection, this lumen is circular, so you have a round shape, and you take this projection, the lumen is still round, it's a circle. If you perform a perfect correlation between the first view and second view, you'll get a perfect 3D. Then the 3D lumen is also a circle. However, if you don't do a perfect correlation between the first view and the second view, then the lumen can become elliptical. So this you have to be very careful because in the 3D reconstruction, if you don't perform a perfect 3D reconstruction, sometimes the geometry is actually less accurate compared to the single view. So this is explained that why in practice sometimes you saw that 3D result is less accurate than the single view. So we further validate this solution in a larger population cohort together with Professor Ku using the flavor study. So in the flavor study, one arm you have FR guided. So we analyze all the angio blindly in our core lab and send the data to Professor Ku in Korea. So compare with the wear-based FR. As you can see that the pre-PCI, the MUFR has a higher diagnostic concordance with wear-based FR. So accuracy was 90%, was a good result. And the feasibility was quite high. Even with respect to analysis, the angio was not obtained according to optimal projection protocol, but with respect to analysis, you can still have feasibility at 95%. So at the same time, we analyze also the post-PCI setting. So in the post-PCI, we analyze post-PCI MUFR. As you can see, lower post-PCI result, the higher target vessel failure in 2 years, and the event really separate after 1 year. So we are going to the 5 years also in the soon also present, and I think the trend will continue. So better to have a better post-PCI physiology in this study. But how to do that? The MUFR software have a virtual standing tool. So as you can see, if you have this is could be useful if you have tandem lesion. So one lesion here and one lesion here. So the software tell you that if you stand the proximal one, the MUFR will improve from 0.74 to 0.95, and if you stand from the distal one, you increase from 0.74 to 78. And using the QFR as a guiding tool, the study showing that 93% of the patient you will have optimal post-PCI physiology is significantly higher than the angio guide arm. So in the study, you see that in the figure, sometimes you see QFR, mu QFR, and FR. Because in China, it's all about QFR. But outside China, we are using MUFR in our technology. It's a bit confusing, if you remember. So now MUFR can be used as a planning tool, but also can be using as a decision making. And this is similar compared to the IVUS in some of the center. So the flavor tool study is trying to assess the clinical value of the MUFR versus IVUS guided in lesion with intermediate lesion. So one arm you have IVUS guided, have a criteria to stand or not stand, and how to optimize it. In the other arm you have MUFR or angio-FR to decide whether stand or not, and also whether to optimize or not. The study was presented this year at ACC and published in Flavor. So it clearly showed that the MUFR is non-inferior to IVUS guided in non-complex lesion. In complex lesion, it may be different, but in non-complex lesion, indeed, the MUFR has comparable results as IVUS. And you can see this type of the table here. So in the study execution, we have 2 generations. The first, that's 175 patients were using the first generation QFR, and the remaining 748 vessel or patients are using the second generation. And see the event rate is lower in the second compared to the first one. On the other hand, the IVUS is comparable in the first and second generation. So these are the table. This table summarized that the randomized trial on the angio-FR. Several vendors are doing that, and we are behind a couple of study that was already published. And outside China, Medicines also had QFR now. I'm going to the microcirculation. See, the epicardial is more or less the topic of QFR, MUFR. Microcirculation is different. So I want to highlight this study that was in Europe, multi-center study with a lot of key opinion leader in this field participate in this study and published in Neurointervention. So this study clearly demonstrated the CFR has a prognostic value, so it predicts the future event. However, the invasive or IMR microcirculation resistance did not predict the future event. So this would be the main result. So I have to highlight that there's some small technical difference here. So the IMR is analyzed here. So it actually analyzed the microcirculation distal to this location. So you will have a, if the microcirculation resistance is if only in this territory, then it can be captured in this measurement. In similar type like the angio-based microcirculation resistance, if you only quantify a single vessel, then you will only quantify the microcirculation, this especially distal to this vessel. However, if you quantify volumetric in a volumetrical way, so meaning that you include all the side branch, also diagonal septal into computation, so you have a more like volumetric analysis, and this will quantify the entire microcirculation of the LAD, like in this case. So it could be different. You remember this? So this has been implemented in the latest AngioPlus software. So we provide two options. First option is a single vessel analysis. As you can see, you have the flow velocity. And the other option you have is a volumetric flow, right? So it's not only quantify the LAD, the main vessel, but also including all the side branches. So you have this flow velocity quantified from the main vessel, and volumetric flow is including all the side branches. So if you have the flow, and if you also can obtain the aorta pressure, you will have the resistance. So if you calculate the resistance now with the software, you have two resistance. One is quantified by the flow velocity in the main vessel, and this will be comparable to the Doppler. In the past, we have combo where Doppler-based resistance, and the other solution is volumetric flow rate. So it quantify all the side branches included here. So this resistance, the unit is going to be different compared to the first one. So be careful about this. But if you are studying, you want to study the entire microcirculation, including the territory supplied by the by the diagonal and septal, it's better to use the second one, the volumetric one. This is very new. So, but if you want to compute the CFR in a volumetric way, you can also do like if you take the resting flow and then get the resting flow and resistance. And if you take the hyperlink flow, you get the hyperlink flow and resistance. You can calculate CFR using the hyperlink flow divided by resting flow. So this would going to be a volumetric analysis. You can also do a single vessel analysis, taking the main vessel flow velocity only. So in this case, see we can calculate volumetric flow computation coronary flow reserve. In this case, is 2.89. So we are testing this in a flavor pilot data set. Flavor pilot test set the feasibility was quite okay if you have a quality image in a good in according to the protocol. So we recently published study. We want to understand the influence of different vasodilator. So as you can see in this study protocol, so first we take the resting angiogram, and then we give nitro and take the second angiogram. So during hyperemia, nitro will induce a little bit hyperemia effect, and then we give adenosine and we take the third angiogram, and then we wait 5 minutes. So really waiting all the vasodilator effect disappear, and then we take the second resting angiogram, and then after 1 minute we can take the nickel and then also take another hyperlink projection, and we want to understand what kind of effect of these different vasodilator, and also whether the resting flow can be reproduced if you have 5 minutes in between. So this will be the small pilot study. And this is the main result. As you can see, is baseline, is resting flow, volumetric flow, and this is also resting flow. And this is the nitro adenosine and nicoradiol. As you can see there, yeah, I was surprised to see that the nitro has also quite good effect on the flow itself, volumetric flow. But this is all patients with a slow flow at baseline. So the difference between different vasodilators is not that big. The nicoradiol has the let's say the highest effect on the dilatation of the microcirculation. So this will be the resist circulation. I'm going to the next topic about the vulnerability. So we also developed the angio-based radial wall strength. The concept can be explained like this. In a vulnerable plaque here, as you can see, more lipid and the zinc cap, the blood pressure is changing from time to time, from systolic pressure to diastolic pressure. So there's a pressure difference there over time. And this pressure difference interact with the plaque composition. If you have a more lipid here, you have more deformation. And the deformation is actually a result of the interaction between the blood pressure and the vulnerability. It happened that this deformation is captured in the dynamic angiogram by visual eyeballing. It's difficult to see in practice. However, if you're using artificial intelligence to very precisely extract the lumen and then matching them, correct them, and then you will be able to quantify this we call it radial wall strength. And the radial wall strength can be indicate about the lesion vulnerability. Although you don't see the lesion, but the more vulnerable plaque, you will have a more deformation. This reflect in radial wall strength. This is the concept. So this we implement this in the Angio Plus software by Post Medical in the version 3. As you can see, after single view MFR, if the quality of the angio is good, and then you can get this co-register color-coded map. The red color indicates the hotspot behind this. The lesion is likely vulnerable. So this is a case that we published. It's a lower coronary artery. Flow is normal. The patient will differ according to guideline. However, the lesion has really a hotspot here. Strength is very high. In 9 months, this location actually caused rupture, plaque rupture, and caused an acute event. So it clearly showed that this could be dangerous in some cases. So we perform a number of validation. This is the first study published in neural intervention, demonstrated the angio-based radial strength actually can has a good concordance with the OCT derived vulnerable plaque. So the lipid to cap ratio, as I demonstrated before, if you don't do OCT, use angio to predict them. You have an error under curve 0.86 in this study. Second study, this is another study that does or will be published soon in JAK intervention. Already published earlier this year in JAK intervention. So using the combined OCT FR data set, as you can see, the OCT vulnerable feature was already analyzed in the combined OCT collab, and we analyzed the angio-based radial wall strength. As you can see on the figure here, the higher radial wall strength, you have a high preference of OCT derived vulnerable feature. And for TACFA, if you have a radial wall strength higher than 12.8%, you have a higher preference of TACFA. And the error under curve is 0.75. How about correlate with the event, clinical event? As you can see, and these are the parameter independent that predict the future target vessel failure or lesion-oriented cardiovascular event. And if you add the radial wall strength and the TACFA together, it's the highest hazard ratio as 3.5 in this population, as you can see here. So if you separate in two groups, in one group, if you're only looking at the false the no OCT development feature. And if you also look into the lower radial strength, they are almost comparable, very low event. But if you have a higher OCT development feature, adding the radial wall strength there, it will further improve the predict value. Another study was published 2 years ago in JAK Invention in Johnson in collaboration with Johnson Hospital. So we analyzed all the patients in Johnson Hospital with two-time angiogram, and the second-time angiogram showing that you have acute myocardial infarction and can be pinpointed to the lesion location. And we analyzed the first angiogram before having this acute myocardial infarction. And using propensity score, we have the control group. As you can see, in patients with acute myocardial infarction, in the first angiogram before having the event, the radial wall strength was higher than the control group, and clearly demonstrated on the figure here. And we also analyzed European population. The target ACES trial is a European trial that we have the 5 years clinical follow-up. And this result was published, always presented this year in Eurointervention. So in collaboration with Dr. Lensky in Yale. So our collab analyzed with Professor William Vine and Galway that the angio-based radial wall strength, and the result was high.
Okay, I think Professor Tu's signal has some problems. Please pay attention. We will contact with Professor Tu. Thank you. Okay, guys. Sorry for everyone. Professor Tu will try to relog in the meeting again. So let's wait for him for 2 minutes. And also for all the audience in the Zoom meeting, so if you have any question, you can also type your question in the chat box. So after the presentation, we will ask the speaker to explain the answers. Thank you. Okay, I think Professor still has some problems, so maybe we can invite Professor Yu to give the next presentation.
Okay, sure.
Okay. First, I would like to introduce Professor Yu. Professor Yu is the director of the Heart Center of Hong Kong Baptist Hospital, and also the clinical professor for the Chinese University of Hong Kong. And also he has a lot of titles, including the associate editor and also the editor board for a lot of important journals. And also today, Professor Yu will give the presentation with the title of IVAS Assisted PCI for Redo CTO. Professor Yu, please.
Thank you very much. Okay. Can you read the slides? Okay.
Yes.
All right. Okay. It's my honor to be invited to give the talk today. So I would like to share with you some experience of the use of IVAS for complex PCI intervention. So now let me present with this case. We have encountered a 70-year-old gentleman who he had been presenting with worsening angina for a few months. He had underlying hypertension, high cholesterol level, LDL 4.2. He's an ex-smoker. He got the CT coronary angiograms done, which actually show a very high calcium score, 1,500 plus. He got triple vessel disease, and from the CT, the LAD, chronic total occlusion, or CTO, was suspected. Now, he had an angiogram done at the regional hospital under the Hospital Authority in Hong Kong in early May. It shows significant triple vessel disease with the left main disease involvement. The vessels were calcified. So they had attempted the PCI for the LAD CTO with the use of microcatheter, including the use of typical CTO guidewise, the guide next family 1, 2, and 3. They got a 2 hours of attempt, just go straight to the CTO first. However, the guidewise since repeatedly went into false lumens, somehow it has some prober at the entry point of the CTO. Therefore, the false lumen somehow was enlarged. At that juncture, I think the procedure was aborted. So the patient was advised to have bypass surgery, but it was strongly refused by the patient. So he came over to our hospital and the clinic for the second opinion, and definitely request to have another go of PCI attempt. So I get hold of the data and the DVD for the first intervention. As you can see in here, with the use of microcath and also guide wire, it seems that it goes into a false lumen on one side, and also on further attempt, it was in actually on different false lumen, including this side and that side, and somehow prober has been tried. And at that juncture, the true lumen blood flow has been reduced, so they decided that the procedure should be aborted. There's no obvious jeopardy of the blood flow. So our approach, so we just did the PCI less than 2 weeks ago. So basically, we do the bilateral puncture. We aim at performing PCI in one go because patient also got a financial constraint. So we did the right side first, and then go to circumflex, and then last to attempt the LAD CTO. Finally, we also do the final left main stenting with kissing. So we got the left radial puncture with 6 French catheter for PCI intervention to the right side. Then we use the 7 French puncture sheath and also for the left CTO operation. My usual workhorse guidewire will be the one full NS. And in terms of the microcatheter, we use the Quasepo and also we use the Guy Nix family. In this case, Guy Nix 1 and also Nix 3 were used. So for the IFS, we use the Ultra Flyer from Pulse Medical. There are some features that that also get a uniqueness of the use of this catheter because as you know, when the frequency is lower, usually you got a better penetration for the ultrasound. However, the resolution may be in more jeopardy. So on the other hand, if the frequency is high, then the resolution will be better. However, the penetration will be another problem. So that actually comes to the features of the latest pulse medical IFS catheter, in that it got a good balance of both the resolution as well as the penetration for the ultrasound. So for example, here is the comparison of other catheter that are commonly used, such as the Boston 40 or 60 megahertz catheter, and this is the Pulse Medical IFS system. Typically, it is a 50 megahertz catheter. It got a pullback of 120 millimeter. SU resolution is 30 micron, so it's good. And also right now you got a pullback speed of 1 millimeter per second. And the future version will be from 0.5 and also with also higher pullback rate as well. So it also integrated with other assessment, including the the UFR for physiology, and also it has some AI-assisted post-processing assessment. For example, the post-PCI stent expansion assessment, side branch, 3D reconstructions, and so on. So here is the procedure. So we go through the left radial and we perform the right side intervention first. It got a diffuse RCA disease, and also it got a trifurcation there. So what we had performed is to put a guide wire and then we do the pullback. As you can see in here, there's multiple regions of fibrocalcific plaques. And also the plug burden is also initially quite large. There's in the middle, there's an area of ataxia that we have to pay attention. And then further pull back, there are also multiple plugs. So to cut short here is the assessment. So we perform the PCI. So because of the distal ataxia, we have to be careful with the balloon dilatation. Now it has diffuse disease as well. So as you can see in here, here is a trifurcation. This is a region with ataxia, and also here is the rest of the mid to proximal to distal RCA with diffuse disease. So from the angiogram here, you can see that initially we got with the stenting at the distal RCA PDA with the use of the QUIC 2.5, and then with post-dilatation, we also have performed POT with the use of larger size balloon like 4 mm. However, on the IFS pullback after the first RCA and the PDA stenting, there is evident that there's region of ataxia. As you can see in here, the stent opposition is not good enough. So we have to use 5.0 balloon for post-dilatation. After that, we also have inserted more stenting to the mid to distal RCA with the use of the QUIC 3.5 and QUIC 4.0 stent. So quite large stent size and also multiple multi-jacket to cover all the regions. So here is the region with ataxia, as you can see from the longitudinal as well as from the SU plane. So after post-dilatation with the 5.0 balloon and also stenting the rest of the mid to distal RCA, that is the final angiogram, and you can see the retrograde going back to the left side system. Now, this is the angio showing external stent apposition from the PDA up to here region of ataxia, where there's no more malopposition, and also further upstream at the mid to distal RCA after stenting. I think the stent has been nicely apposed. So here is the segment, and also you can see on the longitudinal and SU plane, I think the position has been good. In particular, at the region of positive remodeling, the coverage has been good. And also further segments as shown here, all being covered nicely. This is a PDA at close to stent edge. Again, the vessel has been covering quite well by the stent. Here is the next is the angiogram with the circumflex artery. As you can see here, the circumflex get a very tortuous course. The course is tortuous and also multiple region with severe disease, like here at the distal circumflex as well as further down. And also there are regions of calcification also making the passing of the tooth more difficult. So at the IFS pullback, as you can see right here, there's large size fibrous plaque with some eccentric calcification. And here is also segment with some ataxia, more proximal plaques, and so on. So positive remodeling has been present, as shown in here. There are multiple regions with plaque and also very tortuous vessel. So with this then, it was a create 3.5 mm stent was inserted at the distal circumflex, and also from ostial to proximal circumflex. Another create 3.5 times 26 millimeter stent has been inserted. A certain region of ataxia, like here, we also has to use a 5 mm balloon dilatation in order to give an optimized result. So here is an angio showing a nicely opposite and also a good final result. Now here is the post-standing angio, as you can see here, and also here after putting in the two stents, while the IFS showing that at the distal segment as well as here at the athetic segment, I think it has been opposing quite well, and also the final MLA is very satisfactory, and also I think he is up at the ostium of the circumflex, which joined into the left main. Now here it shows the summary of the essential slice at the distal sand edge at the as shown in here, and also at the proximal at the ostial here, just before the left main, which joined here. So the configuration intended will be the T standing after we deal with the LAD. Now for the LAD, we have done a simultaneous injection. As you can see in here, in fact, the rest of the LAD is not that healthy. It does has a diffuse disease with multiple regions of tight stenosis and diffuse stenosis. So here is the missing point with some calcification in between. When the guide wire was inserted, we used the so-called buddy guide wire technique, because even with the floppy wire like the run through NS, it can easily go into the false human on either side, one in here, and then also on further attempt, the guide wire goes to the opposite side in there. So that is the other one, as you can see in here. But I think from the angiogram assessment, it should be in the middle, just at the middle of the calcium where the true lumen lies. So we aim at going there, but in fact, it's not an easy task, because the calcium is there. So after repeated attempt with the microcatheter, we step up guide next one into guide next three. It can engage into the cap and gradually go straight into the into the track. So I think here it shows that it is quite close to the exit point at the distal cap. So after further attempt, I think we are successful. So we drew and penetrate right in the middle of the distal cap and go into the distal true lumen. So from the retrograde injection, it's shown nicely that the wire goes into the true lumen. Then we had exchange, and also we have performed POBA. So we use 2 mm balloon to dilate the whole region from distal to proximal, including the CTO segment. And of course, we perform IFS from distal and pull back to the proximal. IFS actually shows diffuse disease. As you can see in here, that is a region where there's some contrast. That is the false trap being dilated with the balloon from the last attempt. But I think the essential point is that the cause of the guide wire is all in the true lumen, as shown here. And it's very nicely showing in this segment that in fact it was a circumferential, even more than one layer of calcium. But I think the wire go right in the middle, and also but the balloon has able to crack multiple regions of the circumferential calcification. So here it shows the summary. Further distal down, beyond the CTO cap, there is evidence of the hematoma and also the false lumen from the previous operation, and also it shows the circumferential calcification over the CTO segment, which was cracked, and here it shows more proximal segment as well. So we went down from distal and gradually up to the proximal, with the distal getting a very long create 2.5 times 46 mm stent, which was further post-dilated by the 2.75 and also the 3 mm balloons. So and then the proximal to mid segment, it was dilated further and also stented by the create, also with a long stent, 3 times 40 mm, and was post-dilated though to 3.5 and 4 mm balloons. So now here it shows the pullback after intervention. If there was excellent stent deposition at the mid to distal LAD. And also the proximal LAD, at the proximal LAD here, the calcified segment originally, it was fully expanded, and also the false lumen and the old hematoma has been obliterated. There's some malposition here just at the beginning of the osteo region. And also on the pullback, in fact, we were able to show there's some left main disease, as I show you here on the summary of the slides. That is the old hematoma just beyond the CTO cap, so it has been obliterated. That is the stent position here at the ostium. There's a bit of malapose, and here at the very last pullback, there was a rather sizable plug here, which shows a small MLA with only 5+ millimeters square. So what we did is to proceed further pot at the proximal LAD lesion and then perform the stent. So the stent has been stenting at the osteo main up to the proximal segment has been guided by the IFUS with the careful injection of the contrast to locate where is the bifurcation, and also the stent will be overlap with the osteo circumflex stent. Therefore, it is a T-standing approach. After stent implantation, the left main has been further pot by 5.5 mm balloon, and also the rest by 4 mm balloon at the proximal LAD. As you can see in here, it shows a rather nice stent opposition all the way from LAD, and then further down to the proximal part of the LAD, which join nicely into the left main, as shown here. So that is the final angiogram showing the result, and also showing the location of the stent. Now here, sorry, that was a semi-final angiogram. So after the stent, we also had performed the kissing of the LAD and also the circumflex by use of the 2 balloons. So that is the final angiogram with the pot and so on. It shows that all the branches are preserved, and also final result has been very satisfactory. So here is the RAO caudal and the spider wheel showing the nicely opposed stent, and the osteo stent is right in a good location. So here is the very final pullback, which focus at the left proximal LAD, also gradually pull back at the left main. Here is the conjoint. Okay, the guy Y at the circumflex at 4 o'clock. So here the left main, as you can see in here, so all the regions are nicely dilated, and also here is the down to the aortic root. So here is the summary showing different segments at the distal LAD, mid LAD, and also the proximal LAD, and also here it shows close to the ostium, and also at the conference where the circumflex guy Y is joining, and also the left main going all the way up to the ostium. So in terms of the role for IFUS for PCI, especially for CTO, I think it's very helpful because it can help to identify the guy Y entry point when CTO at the bifurcation without a stump. In that case, we can actually put the IVUS into the side bunch and then try to locate where is the stump and perform the puncture to engage into the proximal cap. We can also confirm the guide wire course in the CTO segment and beyond after pullback and decide whether there's any region that has entered into the false lumen. Of course, it is very helpful to perform sizing of the stents and balloon, especially for the underfield LAD like this. The vessel may appear undersized. Therefore, we have to do all our best to actually get the best dilatation and also the good final result. Otherwise, when you do the follow-up in eventually, you might find that the stent might be malposed once the vessel has been filled by pressure. So IVUS is also very useful to guide the osteo location for stenting, especially when we encounter multiple stents. Stent positions is very important. Like here, we have long segment, we have multiple segment, and also we have attetic segments that I think IVUS is a must for the excellent result. And of course, for bifurcation assessment, IVUS provides us a very important information, especially when we encounter left main to LAD and circumflex bifurcation stenting. So I think with that, I will thank you very much for your attention.
Okay, thank you, Professor Yu. I think it's very interesting case with almost 50 slides to into the whole treatment flow. So I see there is a question in the chat box. So I think this one is for you. So if IVUS MLA and IVUS derived UFR are different, one positive and another negative, how to make the decision of treatment?
Okay, so I think the question is the sizing, right? Because I can't see the questions from my okay, let me see. Okay, so in fact now first of all, nowadays many different kinds of stents get a very flexible sizing, so it allows us that we can fit in with different segments. I think that's very important because for example, the stent I'm using with the use of the Create platform, even with the 2.5 stenting, it can easily further dilate up to the size of 3.75 and even 4.0. So it allows a lot of flexibility. So with that, we can more aggressively using long stent. The differential sizing is not issue. And also with many of the state-of-the-art stent, the side hole has been good enough that allow you to easily pass with the guide wire and also allow a good side hole sizing with the use of sizable side hole stents. Even in this case, you can see when we put in 3.5 proximal stent or 4 mm stent, the same platform, we can dilate the stent up to 5.6 mm. The main vessel could be 4 mm and the side bunch could be 3.5 mm without trouble.
Okay, thank you. And also, Professor Yu, I think also regarding to this question, so if you make this kind of case, if the physiology is positive, but the lumen diameter is large, so if there's some conflicts between the stenosis percentage and the physiology numbers, so how, as a clinical physicians, how can you make the decision?
Well, yeah, I think that's a challenging question. You know, I think different methods has been validated in different ways in order to derive, you know, the clinical decision making. First of all, we have to understand that there's probably not a single way of assessment that can actually answer all the queries and questions. Every modality that we use, first of all, when you try to validate against the standard itself may not be the true standard, because even the gold standard is not 100% that can give you confidence that that is all true positive and true negative. So I think that's very important. Secondly, when we perform the assessment with the tools, I think at a certain acceptable level, for example, for accuracy of 70%, you think it's good, but there's still 30% of true positive and true negative, as well as false positive and negative. Under that circumstances, I think we really have to exercise our judgment. For example, on IVUS, there may be features that you think it is not comfortable to leave behind. For example, not only the small MRA, as Professor Tu has mentioned, there are quantitative parameters indicating the stability of the plaque. There's also evidence that sometimes when you see the large core, the lipid core, as well as when you see there's some dissection flaps and so on. I think these are features that will prompt us that I think intervention probably can help. As a whole, I think when we analyze or read the papers, it tells us as a whole batch of patients, it is a general message. But on the other hand, when we perform intervention, we also have to individualize the patient's situation and choose probably the best tools, or you choose the tools that I think you have to be accountable. What features make you to decide whether you should go for intervention or not? Thank you.
Okay, thank you, Professor Yu.
Yeah, if I may add one comment here, Professor Yu, very nice talk.
Thank you, Professor Tu.
We were discussing about physiology for CTO, and frequently we see that when you open the CTO vessel, occlusive vessel, and if you do IVUS or angio, usually you have a negative remodeling in distal segment. And so if you measure physiology immediately after CTO, it's going to be changed over the time, maybe in a couple of weeks. So I think that that field, the physiology, the cutoff value will be different. We should not use the physiology or 0.80 after CTO because of the remodeling.
Absolutely. Yeah, I think I fully agree with you. I think that is very important comment. We also have seen situations like this when you have like a very long disease as well, right? You end up probably need a metal jacket. In those situations, use of physiologic assessment might not be accurate, as you mentioned, because the vessel is under field at that moment, is under pressure. So it hasn't go back into the usual physiology and the size. And then secondly, when the disease segment is too long, in fact, the reference segment will be very minimal. We also have encountered technical situation like when you start with the osteo disease all the way down. There's actually no normal proximal segment for reference. So I think under those situations, then the assessment will be very different. So in fact, it's probably not necessary, right? In those situations with long, severe, or diffuse disease to undergo physiologic assessment, because these patients will need the stent anyway. Thank you very much.
One question I want to ask you, do you use CT in CTO to assess the structure or the anatomy before you are really choosing the strategy?
Yeah, I think that's an important question. Yeah, I do use CT to help. Although in our lab we don't have the usual capability to integrate the CT image into our cath lab angiogram machine, so that it cannot do a direct projection. But because for this case I present is actually not the CT is not done in our setting, and also it was done another hospital where we were not able to get hold of the raw data, and also is a redo case. But in my own case, if I can get hold, yes, I use the CT for assessment, probably to estimate the length, even the calcification, anatomy, angulation, and also tortuosity, especially for long segment of CTO. I think that is very helpful, as a matter of fact.
Thank you.
Thank you.
Okay, I think there's no question regarding to the Professor Yu's presentation. So also thanks again, Professor Yu.
Thank you.
And come back to Professor Tu, I think you can restart from the optimized study in the target AC population.
Okay. Can you see my slide now?
Yes.
Okay. Sorry that my network was not good.
So I had to interrupt. I change another network. So I will start from here where I stopped. So this is study that we performed in collaboration with Alexander Lansky and also William Vines using the target HC study population. So we did a collab analysis, completely blind to the clinical event, and then the data was merged with the clinical event by Professor Lansky. And you can see the result was surprisingly good, especially for non-target vessel revascularization. So if you have a lower radial wall strength in 5 years, less than 1% will have a revascularization. But if you have a higher radial wall strength, then the event rate, or 1 out of 5, will have a revascularization. That's clearly so that it differentiates the risk of revascularization and also for the myocardial infarction. And on the right side, you can see clearly separated the two curves. So higher radial wall strength have a higher event rate over 5 years. This is similar finding we had in the Favor 3 China study that was published in JACA in 2023. So we analyzed all the non-flow limiting vessel in the Favor 3 China. And as you can see from the figure here, if you have a higher radial wall strength, the event rate in 1 year is even higher than if you have a lower radial wall strength. So on the right side, give you with the current practice what we can do with this technology. So there's no evidence that if you have a higher radial strength, you have stent, but if you have a low radial strength in combination with the normal physiology, so if you have a μFR higher than 0.80 and radial strength less than the cutoff value, then the event rate is very low. So it's safely, you can use it safely to differ the vessel. So this is our current recommendation. And now go to intracoronary imaging. So Professor Yi just mentioned the IVUS. So also for OCT, we have a solution to combine IVUS OCT with angiogram. And why do we want to do this combination? Because from time to time, we see that the intracoronary imaging did not cover the entire lesion. So sometimes the distal segment, you still have some residual stenosis that was not covered by the IVUS OCT. So if you do a retrospective analysis, and sometimes you see lower FFR compared to the IVUS OCT FFR. And if you go back to check carefully the data, then you see that there's some residual stenosis that was not covered by the IVUS OCT. So now we can use the combination. So for this segment, we have OCT. For the other, you have angios, and we can put them together, have this hybrid model we call OCT modulated μFR. And see, this is study we assess the accuracy of this OCT μFR compared to the angio guided derived μFR. So we found out that if you have a good image quality in angiogram, so the two technology has almost a similar result. But if you have a worse or a suboptimal angiographic image quality, so including OCT would improve the computation result because it can show the lumen more accurately and as well as the plaque as well. And this has been extended to IVUS. So using angiogram, we can get the contrast flow, and we take the side branch from the angiogram. You have a longer side branch. And from IVUS, you can have lumen and EEL and stent and get the side branch oxtail, and then you can co-register them and combine them together using have this hybrid IVUS module with the μFR. So in Paris, during EuroPCR this year, we saw the correlation with this technology with the target vessel failure in 3 years using the flavor study population. As you can see that in the IVUS modular μFR strongly predict the target vessel failure in 3 years in the flavor study population. So this is the main result. In IVUS now we can also using artificial intelligence to delineate the stent stock automatically and then quantify the stent expansion. So I'm not going into detail of the technology, but in the end, if you have a faster pullback speed. Nowadays, IVUS pullback can be up to 10. Then you can have a more or less continuous 3D visualization if you have a high image acquisition. So with the stent expansion now, you can quantify using the software. So this is a study we did. So we perform stent expansion. And so so here you see this test line here. It's the healthy lumen that we reconstruct from the IVUS. So this will be mimic the lumen, the healthy lumen, before it have any plaque or any remodeling. So the healthy lumen is step down reference diameter because the side branch will take out some of the flow. So this is like our MUFA. We have step down reference lumen. So if the stent size area is completely touching the healthy lumen, that means that the stent is exactly the same size as the healthy lumen. This is a perfect apposition. And if it's less than the healthy lumen, it's if less than 20, 80% is underexpansion. If more than 120, it's overexpansion. So this is what we quantify in the study population. Overall, almost half of them have appropriate expansion, and 36.8% underexpansion and 5% overexpansion. And as you can see that in the distal segment, you have a higher chance of overexpansion. This is predictable because you have a smaller size of the vessel that have more higher chance of overexpansion. And this study is the main result. This slide shows the main result. So proximal radial plaque burden at proximal stent age more than 50%, and overexpansion length higher than 5 millimeter, and MUFA less than 0.90 are independent predictor. And you add them, these three together, you have a very strong predictor value. So this is a surprising result because initially we saw that underexpansion will have also strong impact, but it happened to that the overexpansion, if it's long, then it have it will increase the adverse event, and this maybe explain that if you have over-dilated it, then it can injure the media, and then it will cause more restenosis in the end. So this is a software now is integrated into the IVUS console by Postmedical. So we use the same console and the caster. After pullback, you can immediately get this physiology and the AI-based quantification, including plaque burden and also stent analysis and also physiology result in the same console. In the same time, we are still working on some even more fancy stuff that like using OCT to really image the flow. So this is a paper we published last year. Using the OCT caster, you can image it real time, the flow in real time. And this we hope to bring also this one in the future to clinical practice as well. Then you can perhaps assess the microcirculation with higher accuracy because it's really imaging. So ladies and gentlemen, in conclusion, AI can help extract hidden information from coronary imaging data and enable fast correlation of different imaging modality for comprehensive assessment of coronary physiology and plaque vulnerability. And AI enhanced computational physiology and strength analysis improve patient outcome by changing the treatment strategy and show significant prognosis value in patient undergoing PCI. The integration of the multi-imaging modality by AI offer more intuitive visualization with comprehensive and complementary data, and thus enable improved clinical decision-making, PCI optimization, and as well as resource utilization. So all these AI work were performed by a number of young PhD and postdoc in our lab. Very thankful for the contribution. Thank you for your attention, and if there's any question, I'll be free to discuss.
Okay, thank you, Professor Tu. I see there's some question in the chat box. The first one is from Nadine Malik. Is this helpful to read hard or soft plaque? I think it's regarding to the readable stream.
I think where do you see the?
I think it's in the last part. So is this helpful? Is this radio wave string helpful to read hard or soft plaque?
Oh, okay. So the concept of radio version is really because the blood pressure is changing over time, so it interacts the plaque composition. If you have soft plaque, then you have more deformation. You have higher radial wall strength. If you have a hard, like more fibrous or calcium, so there's less deformation. Then you have a lower radial wall strength. So it's kind of the result of the plaque itself.
Okay. The second one, what's the clinical value of μFR, FFR, AMR, IMR, and the CFR, and how we can use them in the daily cath lab? I think it's about the comprehensive assessment from different physiology.
A very important but difficult question. There are indeed now from Angel we can develop all of these index. I think that it depending on the scenario as well. So if for intermediate lesion and stable patient, you are using MIRFA, and for those also still have a symptom, but no the epicardial stenosis or minor epicardial stenosis, I think it's useful to assess the AMR and also particularly CFR. I think CFR is very useful to differentiate in combination with the AMR, can differentiate structure and functional microcirculation dysfunction. If you're using AMR alone, if for example, like in the past using IMR, the wear-based IMR that measure the resistance at hyperemia, it's difficult to differentiate the structure microcirculation dysfunction or functional microcirculation dysfunction. So then it can influence your decision making. And also the literature I saw there did not show that prognostic value of the IMR. From my point of view, that first of all, the measurement of IMR is also not very easy to make like reproducible measurement with the wear base as well. That it is the according to the feedback we have. And second, that it only measures the resistance induced by this single vessel analysis, as I saw in the figure. And sometimes microcirculation problem is happening in the like diagonal and also septal, and this is not going to capture in the LAD. So maybe using the coronary tree model would have different result. This is a hypothesis that need to be tested in the future. And the so the radial strength is more for backbone ability. So this is different animal compared to the physiology. Indeed, we saw that if you have a let's say low FR or low MFR, the chance of having a vulnerable plaque is higher as well. There are some correlation, but it's not tight correlation. So for individual patient or plaque, if you have assessment for both, it would be, I think, better. I don't know whether I answer your question or not.
Can I also ask Professor Chu question? I enjoy your talk
Sure.
very much. I think you have got a lot of innovation and also new information to share. I'm sure the application will be gradually expanding as when the evidence accumulate and also with more revalidation on the clinical application of the different tools. Now, on practical side, one question I would like to ask you is about the combined IFAS together with the OCT, because I mean these are the anatomical guidance. Of course, there could be functional assessment as well. Now, when we perform the usual OCT, we need to inject the contrast. At the same time, when you do the contrast injection, will you affect the quality and the interpretation of the IFAS image? So will there be any difficulties in performing both at the same time?
So good question. I think that the image quality for IVUS OCT the influence of that one on the computational physiology is less, because the lumen is clearly fibrous modality. So we can use one like OCT is enough to get the lumen. And perhaps adding IVUS there, you have a better understanding of the media and plaque itself, and that could be some advantage in some case. For example, very severe stenosis and very diffuse stenosis, where by OCT you cannot see the media at all. So then it's difficult to get the healthy lumen from that patient. And adding IVUS can be helpful, although the chance is not very high in practice. And I also noticed that there are a couple of hybrid caster, and like you say that the IVUS image quality is not that good in some system, and this is probably the some or in our lab we also have a like not commercialized yet, but a worker in protocol to have a hybrid.
Right.
So it seems that with some technology you can improve this in the future. Yeah.
Thank you very much.
Okay. So I saw one question in the window there is, are the best calculated by only annual projection? Yes. So actually at the beginning we try to use 2 projection. So we do the 3D reconstruction of different cardiac phase and we calculate them. But we found out that it's very difficult to make a reliable analysis, because you need to correlate these 2 projection very precisely. Otherwise, you will introduce some artificial deformation, and this would make the analysis less reliable. So this is in the end, we give up the 2 projection. And what we found out that in practice, if you take the optimal projection, and there is usually expose the lesion well, and also less overlap there, and because the bending and if you go to see the structure of the coronary, by the good projection there, where the plaque is always glow on one side due to the low shear stress, and then there the deformation is usually okay. So it turned out that if you take a good optimal projection, that projection is good for calculation of radial wall strength. This is what we found in practice. And there were a difference in angle requirement for MIRAFA, CFR, and others. This is another good question. I think that the requirement for MIRAFA is minimal compared to the other 2. If you want to do radial wall strength analysis, it's very demanding on the image quality. So first, you need to have a 15 frames per second in the acquisition, and second, the angle of image quality need to be good image quality. Otherwise, because the change is very subtle, very small. So if the image quality is not good, then you influence the result. So the requirement, if you want to perform radial wall strength, is much higher than if you do a MIRAFA. And CFR is more depending on the flow, the contrast injection. So it's not about I think it's not about the system itself, but more about how do you do the contrast injection. Make sure the guiding catheter is parallel to the center line before you inject the contrast. It's the most important step. And also have I think if you have 15 frames per second, it will be better. Because if you have 7.5 in practice, then missing 1 frame, it will have a higher error compared if you're using the 15 frames per second. So this would be the practical term to consider. So if you want to use technology, just post-medical will provide you sufficient training in the also acquisition. This is very important. Only you have good image quality, then you have good result.
Okay, thank you, Professor Tu. And actually, another previously question, so I think it's from Cruz. So the AWS and the CFR is included as additional tools in the MIRAFA software. So I think I can answer this one. So actually, the radial string and also the new developed CFR is still the research function. So currently, they are not in the commercialized MIRAFA software. And also, if you have some research collaboration intents, you can connect with post-medical or locally distributed. So we can also discuss about this research collaboration. Okay, so I think there is no question from the audience, and also it's already the end of today's meeting. So finally, also thanks again for Professor Yu and Professor Tu. So thanks for your time to share your very interested experience and also the research and the clinical practice cases. And also thank you for all the audience. We still have 50 in the Zoom meeting, and also in China we have another platform to give the live of the whole sessions. And also finally, thank you both, and also thank you all for the audience. Have a good night.
Thank you very much. Good
Thank you
night.
all for your interesting.
night.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye bye.
Bye-bye.